I believe so.
All right, I'll bust out my timer. Whenever you guys are ready.
Hello, my name is Nicole Rocca, and my teammates are
Juliana
Emily Sansusi,
Alyssa Webb.
and we are looking to make a drug-eluting artificial bypass graft. So here's the overview of today's presentation. So when there's a blockage in an artery or vein, coronary bypass surgery is normally completed. And so to fix this and then divert the blood around the blockage. So this is a more invasive surgery than the use of stents and therefore requires a longer recovery time. So we're looking to create an artificial bypass graft with a drug-eluting feature to help reduce the recovery time.
So why is it important? So more than 500,000 bypass grafts are performed each year, and this number is expected to increase with the aging population. And about 40% of vein grafts fail within 18 months. Patients with obstructive coronary artery disease can benefit from bypass grafts as it's a form of treatment for this disease due to the buildup in blockages and plaque. And most needs for an artificial graft concern the lack of or unsuited veins. And a few examples would be patients that need multiple grafts, patients that have too many pre-existing veins harvested, and patients with amputations. One of the major unexpected complications that can come with coronary artery bypass grafting is infection. So some of the clients we have are patients who require bypass surgery, will have a blocked or narrowed artery that needs to be treated to restore the blood supply to their heart muscle. These patients can express the following symptoms: chest pain, fatigue, palpitation, abnormal heart rhythms, shortness of breath, swelling in the hands and feet, and indigestion.
So we're looking to manufacture an artificial bypass graft coated in a slow-releasing drug like statin, and statin would help prevent the lipid buildup to help reduce the failure rates. Because it's artificial grafts and other grafts tend to see failure within 18 months because of problems like lipid buildups once again. So we estimated about 200,000 patients a year will have this implanted, which is based off of the 40% of the failed bypass grafts, but it does have a potential to help more patients than estimated. And the surgery and device would then be paid for by patients and the patient's insurance.
The value of our honeycomb in all of it was that of the need to use a healthy artery or vein from an alternate location and highly immediately and underway.
and then for the costs, you have to consider the graft material, the drug, and the manufacturing and research costs. And the estimation for the material would be about $224. For the drug would be about $300, and research costs would likely be at least $15,000 per graft. So in terms of competition, here are just 3 current examples of manufactured bypass grafts that are in different stages of development. There's a hybrid bypass graft, a tissue-engineered vascular graft, and a drug-eluting vascular prosthesis. Some important notes regarding these devices is that they all employ a flexible polymer that permits the pulsive flow of blood. For the second one, a pediatric clinical study showed no complications after short-term monitoring, but after long-term monitoring, 6 of the 42 patients developed stenosis. And then also an in vivo study of the drug-eluting prosthesis in rats showed that the drug release was effective. And then our solution is preferable because the drug release can be used to decrease the lipid buildup on the walls and also decrease inflammation. And if our solution is not implemented, coronary artery bypass surgery will continue to be hindered by the shortcomings of stenosis, and then the drug therapy will be hindered by the requirement for patients to take medications daily.
our audience will be hardly valuable person to perform the bypass surgery in our hundred or being require the bypass surgery.
Good job, team. Glad to see you guys landed in a happy place. All right, Hanson, Sandra,